From the Columbia Cardiogenetics Clinic, a patient with an interesting variant of uncertain significance. The role of cardiogenetics in everyday cardiology practice, a case series. Presented by Jessica Hennessey, MD, PhD, Assistant Professor of Medicine, and Natalie Lippa, MS, CGC, Assistant Professor in Genetic Counseling.
Let's start with the first case, okay? So the first case is called cardiac arrest in a 24-year-old. So 24-year-old guy, really no medical history whatsoever. He presented to the emergency room with subacute, crushing chest pain. He was febrile, which was a little strange. His initial labs, minor troponin leak, but severely elevated inflammatory markers. And he had an echo that demonstrated severe hypokinesis and sort of thickened, maybe edematous type walls with global hypokinesis. This was all actually at an outside hospital who started him on pulse dose steroids right away. But despite that, had VT, VF, arrested, ended up on an ECMO and Impella, ended up with an EF of 10% and unclear etiology. Had a biopsy, notably after the steroids and everything were given as well. That was negative. His ECG on ECMO, I don't know, this I thought was a really, from a genetics and an EP perspective, was a little bit interesting. If you draw your attention to V1 and V2, you sort of see a little bit of ST elevation, a little bit of J point elevation. To me, when I saw this, I thought about Brugada syndrome, but we weren't really sure at that time. It got a little bit better off of ECMO when he was recovering. And ultimately, literally in 5 days, his EF went from effectively 0 to normal. His right ventricle looked normal. His cardiac MRI had no LGE, and an ICD was placed. After that, given kind of the very unclear etiology of all of this in this 24-year-old kid, we were consulted.
So during the cardiogenetic consultation, we of course obtained a family history. And you can see here, there's really not a strong family history of cardiac disease. The proband has a great uncle who died of a cardiac event in his 70s. His mom has a history of hypertension, and she has reportedly had normal EKGs, but she's not had any other cardiac evaluations or tests. The dad side of the family history is a bit limited. Overall, the family history is a bit limited. The patient doesn't have any other brothers or sisters. His mom doesn't have any other brothers or sisters. And so given kind of this limited family structure and his young age of presentation, we decided to order a broad-based panel that covers both the cardiomyopathy genes and the arrhythmia genes. And in terms of the results, the analysis came back with a variant of uncertain significance in the RYR2 gene. And, on first glance, this variant is really interesting. It's a frameshift variant. It's in the middle of the protein, and the transcript is expressed in the heart tissue. The variant itself is rare. It's not in NOMAD. It's not in any population databases. And it's not been previously reported to cause disease. And so when we're thinking about how to interpret a VUS, really the first step is to look at what's the established gene disease association. And for this case, RYR2 is associated with CPVT. Most of you in the room may know or do know that this is associated with episodic syncope that occurs during exercise or acute emotion. And usually the arrhythmias self-terminate and patients recover, but in other instances, the VT may degenerate into VF and cause sudden death. But the mean age of onset is about 12 years and usually presents with syncope. 30% of individuals do have at least one cardiac arrest, but this phenotype doesn't really match our patient. So then when we look kind of at the disease mechanism for CPVT, we know it's a gain of function from missense mutations. The RYR2 channel mediates the release of calcium into the cytosol, and that triggers cardiac muscle contraction. So aberrant channel activation can lead to cardiac arrhythmias. When we look at NOMAD, we see that the Z-score here is about 6. That's really high, and that's reflective that the gene is actually very intolerant to missense variants. But if you look at the PLI, that's actually close to 1. It is 1, and this suggests that the gene is also intolerant to loss of function mutations. So as we're going deeper into this, we check out ClinVar. And you can see here that ClinVar has a definitive association with CPVT and RYR2. But if you look at the score for haploinsufficiency, which is kind of related to that PLI score, you see that there's no evidence for haploinsufficiency, but that report was done in 2015. So we're kind of going deeper and deeper into this VUS and trying to figure out what's going on. So since 2015, there's been other papers that have been published looking at loss of function mutations in RYR2. This paper here coined the term cardiac ryanodine calcium release deficiency syndrome. In this case, they looked at missense variants in patients who had negative exercise tests, but variants in the RYR2, missense variants in RYR2. These were all determined to be loss of function variants by functional work. And then this paper here actually looked at stop gain variants. But in terms of like putting this together for our patient's variant is where the star is. And really all of the other studied mutations that are showing loss of function effects are in a different domain. They're not quite nearby our patient's variant. And so although it's an interesting variant, it still is a variant of uncertain significance. We added it to GeneMatcher, and we're hoping to connect with others who may be looking at similar mutations, but there's really no change in management here. We decided not to do cascade testing in this case because of the family history structure. There was nobody in the family with an affected phenotype who could help rule in this variant, and nobody who could really help rule out the variant. And so really we decided to rely on our clinical screenings for all first-degree relatives for the patient, and then to reassess the variant periodically over time, hoping we match with people on GeneMatcher, and who knows what might happen in the future.
This was brought to you by the Center for Precision Medicine and Genomics at Columbia. This has been an internal medicine genetics case study.